a moment in my career when I was a paramedic that changed my life. I was sitting having lunch. I was actually having lunch with a good friend who's in charge of quality. And this medic comes in all cheery and bouncing up and down. And I said, "What happened?" And she said it this way: "I've been a medic a year and I haven't killed anyone yet." And that was what she was excited about. And this bothered me. Because maybe I was sheltered, I don't know. But I looked at it and said, okay, well, if this is what people expect, that what they're excited about is they haven't killed anyone yet, that's a pretty low bar. So I asked my friend who was in charge of quality, I said this question, I said, help me understand, what percentage of our staff would you trust to take care of your own family? And she said it this way. She started counting. She said, I trust 8. I said, 8? Out of how many? She said, out of 80. And this took me aback. 8 out of 80. And my question was, if you wouldn't trust the other 72 to take care of your family, why do you trust to take care of mine? And the answer was, I need meat in the seat. I need the ambulance to roll. And it's personal to me. My mother's disabled, so literally when I see a patient, I see my mother. And that to me is just not good, that we don't trust our caregivers. By the way, it turns out trust and who you would trust to take care of your own family is a little bit subjective, but it really is how you do what you do. But that's another topic. So I started on this search to find out, why do we trust some and not trust others? And why is it when you have people with 10 years experience, half the room's phenomenal, half's like their first day? And the answer was the way they learn from their experiences. And that's why I got into simulation. And that's why my background is actually in adult learning, experiential learning. If you're going to change outcomes at the patient's bedside, which is one of the 5 core principles for learning in healthcare, you need to look at things a little differently. You need to be able to change the learner, their experience, and their environment. In debriefing, people often don't think of all 3 of those. We think of the simulation, we think of the debriefing afterwards, but all 3 need to be taken into account in order to change outcomes. We're going to start with the environment. The environment is very important. There's a lot of research now, and Jenny Rudolph and her team did a great article in Simulation Healthcare on this, on creating a safe container for learning and creating psychological safety. It's so important to create that local environment, I call it the lowercase e environment, to be psychologically safe, because what's happening is we're actually seeing people scarred by their simulation experiences. Now that could be because of the environment, could be because of the experience. Either way, we need to start with the environment. To create a psychologically safe environment, people are used to a lot of things. Vegas rules, what happens here stays here. Fiction contract, which says, I'm going to do the best I can as a simulation educator to make it real. The student has to buy in. And, of course, orienting the student to the room. Now, when you do the orientation of the room, you want to make sure they know what's live, what's not. You're using live defibrillator, are you using real needles, are you using real medications? You also want to make sure you put in a safe word, such as orangutan. If the word orangutan is ever spoken, all simulations should stop. It's a way to cue people in if there's something dangerous happening, or if something real happened during a simulation, such as somebody passing out or a real medical emergency. The other part of the environment, when you look at this overall psychological safety, to me, is students need to know what's expected of them. Are they there to learn, or are they there to be tested? What happens in simulations, we're often mixing formative assessments and summative assessments and doing those on the same days, and the students get confused. And when they're confused, they don't feel safe. For example, if I'm there for formative feedback, if I make a mistake, that's okay and I can talk about it. If I'm there to be tested, it's a completely different bar. Now, some schools believe, well, we're doing formative feedback, but we keep track just for records. Well, if you're keeping track, then it's not truly formative. Because if that record can ever be used against a student, to them, that might hurt the safety of the room. Now, the other part of it is, why are you using simulation? So, I'm starting to see people that are actually scarred from simulation in the way a traumatic event would scar them. I watched this student. We said, okay, we're going to go do some simulations. And she went, poof, hives, head to toe. She was absolutely had a physical reaction to it. And what happened a couple weeks later, I had another student said, we're going to do a simulation. And she went in the bathroom and was vomiting. And I had another student 2 weeks later who was in and out of the bathroom the entire time. And when I started looking at it, actually talked to each of the students, they actually all came from the same school, which told me the simulation program they were going through was causing damage. And here's what I found out. What I found out was when they were in clinicals and made a mistake, they had to go to simulation. That made the simulation the principal's office or the bad boy school. And to make it worse, what would happen is 6 of their peers would sit there with a chart and mark off whether they did poorly or not, knowing that that student had to come to simulation for a mistake. What happens is you need to create a psychologically safe environment for learning, which goes in your entire course design, and you may have to actually reteach people who've had previous experiences about simulation. So we talked about the environment. I want to talk about the learner for a second. Turns out with adults, of course, adults learn what they want to learn when they want to learn it. So if they don't want to learn, that's it. So we need to make sure that simulation is used for the best things that adults actually want to learn. That means things they can put into practice. We need to make sure everything is very practical. Now, you'd think simulation at its core is practical, but it's a time basis. If I'm learning my critical care skills today, but I'm not going to be in a critical care unit for the next 6 months, that's not valuable to me as a learner because it's not immediate. We need to make sure something they can see. The other part of it is they need to see the value in their change in their practice. To do that, we need to actually focus on engaging them in building critical thinking skills. Building critical thinking skills requires both the learner and the debriefer to actively work on mental models of practice. Mental models or frames are the way we look at the world, and we use these all the time in healthcare. Most common one is a patient sick or not sick? I had a nurse tell me, an emergency department nurse tell me that she can tell if a patient can live or die by looking at his feet. First of all, that sounded a little disgusting, but it was real because in a major medical or trauma room, that might be all she sees. So she's using skin color, texture, tone. Those are the things that experience gives you. Most of your mental models are tacit. They're the gut feel, your spidey sense, about 80%. Very small percentage, about 20% of what we know is explicit or knowledge or facts or figures. We need the learner to engage in building mental models. And that's why debriefing is so important. Debriefing will help identify mental models and shift them. So we've talked about the learner and the environment. We haven't even got an experience yet, and that's the core of simulation. Experiential learning, David Kolb, modern father, is a cycle. And Kolb says it this way, it goes from concrete experience to reflective observation to abstract conceptualization to active experimentation. And I had a surgeon tell me once, Jason, I have no clue what you're talking about with those terms. They mean nothing to me. Can you put it in English? So here's how I talk about it. Do, reflect, think, redo. Now, for those that are purists in theory, not exactly right, close enough though. Do, reflect, think, redo. It turns out most of our learning is not actually from the experience. If we just repeat experiences over and over, we're not necessarily going to learn from them. You've seen the student that can do the same mistake over and over and over and learn nothing. And in residencies, they're now talking about having to extend residencies for more experiences. And I love looking at this. Surgeons have a program called Fix the 5 to actually look at the 5 years of residency. And there's a lot of magical numbers in surgery that you need 100 liver cases to be competent. Does that mean at 99 you have no clue what you're doing, at 101 you do? That's not realistic, but we have these magic numbers of experiences. What actually happens is if we can learn better from our experiences, we'll actually get more out of them. So here's what we need to do. We need, as facilitators of learning, to encourage learners to go through the entire cycle. Learners will like one component or another. There's experiential learning styles, which we'll talk about in another talk. What we need to do is, after they have the experience, we need to help them on that reflection. Reflection's simple. When we do that reflection, we as facilitators of learning may see different things than the learner does, and we may be able to use video-based debriefing to help on that also. Once they've identified what worked, what didn't, we need them to think about, well, why? And what would you do differently next time? That's that thinking part. Then they need to redo. Now, redoing is probably the component we do least in simulation. What happens is if I have an experience, I try out my mental model, it doesn't work, I figure out how to do it better, and I don't do the redo, if I don't get that experience very quickly, most researchers would say about 2 weeks, I'll go back to my old mental model. So we need to invite them to redo. Now redo, by the way, because of logistics, we may not be able to actually have the students go do it themselves. There are ways to do vicarious learning. There are ways to do mental exercises for the redo, but it's a component. Now people ask, well, how long should I spend on each? Well, if I have an hour, it's about 15 minutes doing, 15 minutes reflecting, 15 minutes thinking, and 15 minutes redoing. And to break that down a little bit further, I should have about 3 objectives, and each objective is about 5 minutes in each area, because I want them to go through the entire cycle. So here's the secret of simulation. The secret of simulation, we're actually teaching people how to learn. You can call it practice-based learning, you can call it reflective practitioner, mindful practice, whatever it is, deliberate practice. We're teaching them how to shift their own mental model and learn from experience. Students often don't know how to do that. So one of the other components of the environment that we need to make sure we have is skilled mentors. Skilled mentors both at the bedside and in simulation. Over the series of talks here at Learning in Healthcare, we're going to try to give you more skills. But if you are looking for a faculty development course that can help you on how to change outcomes and improve your simulation, connect with us at www.learninginhealthcare.com.